Good morning. Thank you, organizing committee, for inviting to the conference. So my abstract was 5-year outcomes of perioperative chemotherapy and immunotherapy in stage 3 non-small cell lung cancer. So as we all know, lung cancer is the leading cause of cancer-related mortality, and non-small cell lung cancer accounts for 85% of the patients, and 30% of the patient present with resectability upfront. And as we know, this is the historic data that stage 3 lung cancer, the 5-year overall survivals are only 36%. We had came a long way with significant improvement in both EFS and overall survival with the implementation of immunotherapy and chemotherapy. These are all the trials which are discussed previously. Some approvals are based on only FDA, some approvals are from the European organization. So as these are already been discussed previously, so this is a 5-year update of NADIM trial. This is a single arm trial which has given 3 cycles of paclicarbo and nivolumab followed by surgery, and after surgery patient received 4 months of nivolumab with 240 milligram two weekly, followed by once a 480 milligrams for 8 months. So previously we had already seen the primary endpoint is progression-free survival at 2 years. The 2-year progression-free survival was 77%, and currently we will be looking at the 5-year survival outcome. And the significance of immunotherapy biomarkers like PD-L1, tumor mutation burden, and circulatory tumor DNA. Coming to the baseline characteristics, the N2 disease contribute to 33% of the patient, and multi-station constitute to 75% of the patients. Coming to the follow-up, some of the relevant events which happened in the 5-year follow-up, there are 5 non-lung cancer related deaths, 4 patients who had complete pathological response, and 1 patient in non-PCR. 3 of these events are due to COVID-19, and 1 due to pneumonia. One is due to the secondary cancer like pancreatic cancer death. And 9 cancer related deaths, 3 patients who had not been resected had cancer progression related deaths, and other 6 patients who had resected, 3 are of the non-complete pathological response, 2 in major pathological response, and 1 in complete pathological response. Coming to the final 5-year update, these are the secondary outcomes of the study. The 5-year progression-free survival is 65%, and the 5-year overall survival is 69% in intention to treat population. Coming to the per protocol population, the 5-year overall survival is 78%, and progression-free survival is 75%. Coming to if you excluded the 5 non-lung cancer related deaths, the 5-year progression-free survival is 75%, and 5-year overall survival is 82%. Coming to the exploratory biomarkers, in this one we had compared patients who had achieved complete pathological response versus non-complete pathological response. This non-complete pathological response included both major pathological response, that is less than 10% viable tumors, and also more than 10% viable tumor. We can see a significant difference in outcomes, both in terms of progression-free survival and overall survival. The patient who achieved a complete pathological response has a PFS of 60%, not 92% compared with 60% for patient who didn't achieve complete pathological response. Similarly, for overall survival, it is 95% versus 66%. Coming to the other predictive biomarkers, we can see that there is no significant difference between outcomes for the patient who has PD-L1 positive versus PD-L1 negative. Similarly, there is no significant difference for the patients who had tumor mutation burden high versus low. Coming to the other biomarkers, they had compared with respect to the circulatory tumor DNA at baseline for the patients who had mutation allelic frequency of more than 1% versus less than 1%. Patient who had more than 1% mutation allelic frequency at baseline has a PFS of 83%, compared with 48% for patient who had more than 1%. Similarly, for overall survival also, there is a significant difference with respect to the circulatory tumor DNA burden at baseline. More than 1% seems to has done well with respect to the 5-year outcomes. Similarly, for circulatory tumor DNA clearance, by definition means less than 0.1% or undetectable circulatory tumor DNA. So for the patient who had done circulatory tumor DNA clearance have better outcomes in terms of both progression-free survival and overall survival. Coming to the conclusion, as we see, there is a robust clinical benefit of perioperative immunotherapy. This is the study which had the longest follow-up of 5 years. And this study included only stage 3A resectable non-small cell lung cancer with 5-year progression-free survival of 65% and 5-year overall survival of 69%. As we have seen, historically the 5-year overall survival for stage 3A non-small lung cancer is 36%. And there is no signs of late toxicity or treatment-related death. And as with similar to the other immunotherapy trials, particular benefit was seen in patients who achieved complete pathological response, and it serves as a good surrogate for overall survival. And other important biomarker is circulatory tumor DNA clearance. After neoadjuvant treatment showed good prediction for a progression-free survival and overall survival. And this circulatory tumor DNA clearance is particularly important in worse prognosis group, like who doesn't achieve pathological complete response. In patients who achieved pathological complete response, even if the patient doesn't had circulated tumor DNA clearance, there is no difference in terms of progression-free survival and overall survival. And other important factor is for the patient who doesn't underwent surgery with this therapy, but the patient has cleared circulatory tumor DNA clearance. If the patient is alive at 3 years, who is alive at 3 years, till 5 years follow-up, the patient has not had an event in the follow-up. And neither PD-L1 percentage or TMB or markers of PFS and overall survival in this exploratory analysis. Coming to the limitations of this study, the sample size is small, and similar to the other single-arm trials, there is a lack of control arm, and these are subgroup analysis. This has to be taken with caution, and these are hypotheses generating which should be evaluated in the larger clinical trials. Thank you.